I'll now go on to our next team because we'll be really running short of time. Our fifth team is led by Dr. Jaspreet Singh, a young neuro-ophthalmologist from PGI Chandigarh, who's going to be talking on all cases of optic neuritis should be extensively worked with imaging and blood studies. He's going to be contested by Dr. Mahesh Kumar, who heads the neuro-ophthalmology department of Arvind Hospital, Madurai, a very eminent teacher himself. So on to you, Dr. Jaspreet. I think we'll have to stick to just one question each.
Yeah. I'd like to thank Dr. Chitra, ARC and Team AIOS for extending this invitation to be part of this interesting debate. And I would be speaking on whether patients of optic neuritis should be worked up extensively. Yeah, so optic neuritis is no doubt a clinical diagnosis. For making a diagnosis, you really don't require any imaging. But what happens next? The older paradigm was you have a young female RAPD with visual loss and a normal fundus. You give IV steroids, and that was it. Because earlier there was nothing for MS. Until the treatment for MS came, that is when the ONTT came into existence in the New England Journal of Medicine, where they showed that brain MRI is crucial in stratifying the future risk of MS in patients of optic neuritis. So every patient, they would advise a contrast-enhanced MRI to see for any periventricular white lesions. So if it was negative for MS, they may or may not would prescribe steroids. They did say that steroids would not change the final outcome. So what is optic neuritis, the etiology? It's not just MS. You have such a varied causation of optic neuritis, demyelinating lesions, which are the commonest like MS. You have axonal loss like neuromyelitis optica. Then you have certain other autoimmune diseases which cause optic neuritis. You have infectious, para-infectious, inflammatory, paraneoplastic diseases. All these can cause optic neuritis. But yes, I would be stressing on just the commoner causes, which are the demyelinating lesions. So in these few years, I mean, after 2004, there have been the discovery of new glial antibodies like anti-MOG, aquaporin 4, glial fibrillatory acidic proteins. This has really helped us understand the disease because there is a clinical overlap between a typical, which is an MS-related, and a non-MS-related optic neuritis. So how do we differentiate between the two? When there's so much ethnic variation, when you see the neuromyelitis optica in 20 to 48% of Asians and just 1 to 3% of Caucasians. So the only way to differentiate between them with affirmation is to investigate. And why we need to investigate? Because the management and the prognosis for each subset is different. Now, is every optic neuritis MS? The latest criteria for diagnosis are based on investigations. You have to investigate. The McDonald's criteria in 2017 had MRI features as the key to define the risk of MS along with or without CSF band. So with all this, a misdiagnosis can be avoided. So what's the difference between an MS-related optic neuritis versus a non-MS? I mean, there is so much overlap between the phenotype. It could be unilateral, it could be bilateral. The severity of visual loss can vary from mild to severe. So with so much of overlap, what do you want to see? You want to investigate them, whether there are any lesions which are typical on MRI, what is the optic nerve involvement, whether it's anterior, whether it's middle, or whether it involves the posterior part or the whole part, whether it's extending to the chiasma, whether the spinal cord is involved, whether there is any tissue destruction and cavitation. MRI would give you an answer to all these things. And yes, with the evidence of biomarkers, things have started to change. So the red flags in optic neuritis, where you can advise, I mean, what's going on, how aggressive your management should be, are based on bloods and imaging. None of the clinical presentations are diagnostic for the atypical variety of optic neuritis, and if the antibodies are not detected. Conversely, the continuum of this NMOSD, that's a neuromyelitis spectrum disorder, can be wider based on the presence of aquaporin 4 IgG antibodies in milder spinal cord syndrome. So you need to investigate if it's, I mean, because it can go anyway. Then the antibodies are associated with similar syndromes. So neuroimaging finding of MS do not necessarily exclude the diagnosis of NMOSD, as they can occur in patients who are seropositive. So again, an overlap, you need to investigate. The treatment is very different, both of them. The chronic treatment is absolutely different. So you have to have a real diagnosis. So MRI brain can be normal in MS and NMO spectrum. Imaging should be added to these. With such a variable spectrum of optic neuritis and systemic etiology being associated, testing should be mandatory in all cases. And I like to conclude here, in the era of biomarkers, the way we look at optic neuritis has changed. The pattern of optic nerve enhancement on MRI provides diagnostic clues to etiology. It helps us to understand the mechanism of the disease, thus influencing treatment. And with such a phenotypic overlap between multiple sclerosis, aquaporin 4, neuromyelitis spectrum, MOG, and other autoimmune diseases and paraneoplastic syndrome, it is important to appreciate that they are separate entities with differing prognosis, underlying pathophysiology, and most importantly, we have optimal treatment for them. So we should investigate all cases of optic neuritis.
Thank you
so much for your hearing.
Thank you very much.